Marhaba. Hello, everyone. Thank you for joining me to this live webinar. Today, I'll be talking about the socket shield technique and cover some of the myths and realities regarding this new technique that almost everybody in implant industry has heard about this technique so far. Uh, so to start with, let's start with this main question a lot of general dentists and my colleagues ask me about. What has the shield to do with implant dentistry? Why should we really care about this technique? What's going on? A lot of people, they don't have understanding for the whole technique itself. It's a new technique. It's been published for the last uh, 8 years so far. So we are still building our understanding for the technique in implants. And today, I hope that we're gonna cover the whole idea of what is the socket shield technique, what does the literature say about the technique, steps of the technique, what do we know about this technique so far, and discuss at the end of the presentation, discuss the myth and the realities that we know. Obviously, this presentation is not going to be focusing on teaching the technique. So it's only a brainstorming about what we know, what we don't know about the socket shield technique. To start with this disclaimer, there is no conflict of interest in this presentation, no financial benefit by any sponsorship mean, and all the cases were treated by myself unless mentioned otherwise. Partial extraction therapy, or the socket shield technique, um, is part of this partial extraction therapy, or what I love to call it the PDL mediated ridge preservation. The simple principle about this partial extraction therapy is as long as we preserve the alveolar bone by preserving the PDL itself. So we're trying always to trick the biology to keep the PDL intact inside the bone so we can preserve the bone. We already know the root submergence technique, which has been described for a long time ago. Submerging a root just to preserve the alveolar ridge, even before the implant dentistry under the bridges. The Pontic shield is another technique to preserve part of the tooth inside or underneath the Pontic just to preserve the bone. And recently, the socket shield, which is associated with implant dentistry, which could be related or strictly related to immediate implant placement or delayed implant placement. So the bottom line, whenever we discuss socket shield technique, it's mainly this idea: preserve the alveolar bone by preserving the PDL. If we went back to the literature to see what we know exactly about this. We all know that after extraction we have dimensional ridge changes, so we have some bone resorption happens all the time after the extraction. It's very famous, Arajo and Lande studies showing how we lose, how the bundle bone will be resorbed after the extraction, and how the buccolingual dimension and even the vertical dimension of the socket after the extraction changes. So we've been aware of the changes in the alveolar ridge after the extraction, after losing the intact of the PDL to the bone itself. Back in the 1970s, Dr. Bob O'Neill, my good mentor and friend, he published papers to submerge of the root for alveolar bone preservation. So people, they were aware and they show exactly that this is a method just to preserve the bone around the area of the work. So what they did, they tried to submerge some root. In this case, it was root canal treated, and they observed that the alveolar ridge is already preserved from this. A lot of other studies coming from either Europe or from the US showing that whenever we are trying to preserve the PDL or preserve the tooth, we can preserve the alveolar ridge either by root submergence or even by replantation of teeth. Uh, um, the partial extraction therapy came exactly from this idea. The main idea of the socket shield is to, instead of extracting the whole tooth itself, we try to separate the tooth into some palatal and buccal sections and try to keep the buccal section intact into the buccal bony plate. And of course, we will deal with the shield, which is going to shield the implant itself and trying to protect any bone resorption, the implant from any bone resorption or bone loss itself. So the original technique is associated with immediate implant placement, and the shield itself, the part of the tooth that is left, is meant to be permanent there. So we're not planning to remove it anywhere. Gluckman and Salama has some two parts, actually, studies showing step by step and what we know exactly about the therapy so far. It was published in 2017. So let's talk a little bit practical and see exactly what does this mean in clinical case. In this case, actually, I had this tooth number 9, the central incisor, failing. A CBCT is essential actually to evaluate the positioning of the tooth and to make sure exactly we have enough bone. And we will start with separating the buccal aspect of the tooth into the palatal aspect. We usually do some radiographic control during the separation to make sure we are in the same vertical and mesial distal dimensions. After separating the tooth into buccal and lingual, we gently remove actually the palatal aspect of the tooth, and we make sure that we are leaving the buccal aspect, which is going to be the shield down the line, intact into the bone with no stability. And we spend some time shaving the shield and some criteria that I'm going to discuss later on, just to make sure that we have some good prosthetic space for the crown in the future. Placing the implant has no difference than the immediate implant placement. We need some initial stability, and we are planning to have a gap somewhere between 1 to 1.5 millimeter between the implant and the shield, which could be filled, should be filled if it is 1.5 millimeter with bone graft. And we control this. Personally, I control this most of the time with the CBCT, is just showing the implant inside and the buccal plate intact, and we can see the shield just protecting the implant itself. And after this, we need to make sure that we are supporting the soft tissue exactly like any immediate implant principle, with some temporary either custom healing abutment or with a temporary crown itself, depending on the initial stability of the implant. So the implant is there, the shield is intact, and it's really stable. We have the bone graft ready. We prepare our mainly, in this case it was provisional full crown, with any method, either chairside or either prefabricated at the lab, or the digital implant dentistry, or any guided surgery. And the main goal is just to use this crown to support the soft tissue around the implant. So let's go a little bit backward. This is the technique. We are aiming to leave part of the tooth intact into the buccal plate and trying to leave it there so it can act as a shield protection into the implant, hoping that is going to preserve the bone and preserve even the soft tissue, and supporting this actually with what we know from the immediate implant placements, with some temporary immediate temporization. And we all know whenever we have a failing tooth, we have two different options, either to do extraction, ridge preservation, and delayed implant placement, early delayed. or to do immediate implant placement with or without provisional prosthesis, which we have enough literature to support. And we know that the immediate implant will provide us with fast method, less painful, less surgeries, tissue preservation, either bone or soft tissue, aesthetics, and it's predictable. So in the literature, we already have, since the 1990s, we have enough papers describing that, like Reader, describing that the immediate implant and immediate restoration appear to be a viable alternative to early implant placement. An experienced surgeon is trusted with the implantation procedure. Uh, Can and a group from Loma Linda University always show that it's high predictable to have an immediate implant with immediate provisionalization into the anterior teeth, and they showed a lot of successful long-term studies for this. In the ITI treatment guide, Boozer and Chen, they described actually the low and high risk of doing immediate implant placement, starting from getting low risk if the patients have low aesthetic expectations, low lip line, low scallop and thick tissue biotype, and the shape of the tooth rectangular. And it's high risk in their studies if the patient is a heavy smoker, which is more than 10 cigarettes a day, and the patient is with high expectations, the lip line is high, it's thin biotype, or the teeth are triangular. Down the line, we developed actually some understanding, and we had some consensus actually about the immediate implant placement. And we all know that whenever we place an immediate implant, we need to engage the implant into the palatal plate, leaving a jumping distance somewhere between 1.5 to 2 millimeter, actually trying to avoid any engagement into the buccal plate and make sure that we have a good restoration. This beautiful demonstration is from my friend Francisco Barbosa. I thank him for letting me use him. And then Can et al. In 2003, starting from 2003 with Lozada, actually, they started to make a classification actually for the teeth positioning inside the ridge, the alveolar ridge. And they just divided this into type 1, which is we have the tooth engaged actually in the buccal plate, and we have enough bone in the palatal which we can put our implant in, and it's the favorable to place an immediate implant. We have type 2, which is the tooth will be in the middle, so we don't have enough bone either or. Type 3, we have the tooth engaged into the palatal plate with only possibility of engaging the implant in the middle or on the buccal plate, and type 5, which is not a good option to do an immediate implant. So we have understanding for immediate implant, and whenever we do socket shield, we need to make sure that we are doing the same principles of immediate implants with the socket shield. So what's the long-term predictability of immediate implants? We've been doing this long enough and we've seen a lot of success. Let's talk about this quick case here. We have a tooth, it's a type 1, it's good for immediate implant. We did a traumatic extraction. I used here the Benex machine. I love it actually. And then we do the preparation into the palatal plate, placing our implant. We have the jumping distance, 2 millimeter. In this case, I followed the surgery veneer grafting for Agnini Brothers, and we used the connective tissue graft to support actually the buccal aspect of this, using the immediate provisional custom healing abutment here to support the soft tissue. And down the line, we can see that we have soft tissue stability here. So we use the bone graft also in this case. So extraction of the tooth, the provisional custom healing abutment. After 4 months of the implant placement, we have stability in the tissues, and even after delivering the final crown, This picture is 1 year after delivering of the crown. We still have some stability actually of the soft tissue in general. So we have high success rate in immediate implants, but the fact is we still have some issues with long-term prognosis of immediate implants. We have some recession, gingival recession, and who practices implant dentistry knows exactly that we have this problems either by losing soft and hard tissue, exposure of the threads, some of the buccolingual loss of the bone width. And for this immediate implant, we followed this for 3 years, and we had a huge bone loss at the buccal plate of the implant. So we have some issues in immediate implants. That doesn't mean that immediate implant with the traditional ways that we've been doing is unpredictable, but we see some long-term issues all the time. And this is actually proved by the literature. We have labial bone remodeling, we have bridge collapse, tissue recession, color changes, implant stability, buccolingual collapse, gingival recession, and loss of the papilla. Can from Loma Linda again, because the group is big in immediate implants, they followed actually with a lot of cases for long term, and they saw a lot of those problems just occur with the implant placement. DeRogue, actually, this is one of the studies that I love, single tooth replacement in the anterior maxilla by means of immediate implant and provincialization. They showed that we have some issues, especially with poor case selection, and we need to have strict guidelines for immediate implants to bump the success rate higher. So the long term has some question marks and immediate implants, especially with the aesthetic zone. And as I said, we have some evidence-based data showing that we have a lot of recession, some of the high demand